Pat, welcome to the college and thank you for coming today to talk to us about your very interesting and varied career. You've done a great deal with your career, but I'd like to start by talking about where you came from. So that's New Zealand?
Yes, I am originally a New Zealander, though I'm now a naturalised Australian. I came from a little town called Balclutha, south of Dunedin, and trained at the Otago Medical School.
So you started your anaesthetic interest in New Zealand?
I was terribly lucky when I was giving anaesthetics. I liked it. One day I was assigned to a caesarean section all by myself, and the obstetrician said, "Oh, it doesn't matter, the baby's dead." And the baby turned out to be alive, so that made my career.
Oh my goodness. Yes. What sort of anaesthetic did you give to bring this baby back to life?
I think just a very good open ether.
Yeah? With the Schimmelbusch mask? Or?
Yes, yeah. That's all we had.
During your career, you must have seen a lot of change in the equipment that we use and a lot of change in the reporting of things resulting from equipment. What do you think the biggest changes are?
Well, when I started, we were lucky to have a machine, and I can recall particularly that our director, John Ritchie, was usually got the machine first, and the rest of us had to use open ether or high spinal. Those were the two alternatives, but they were all pretty primitive, and certainly the draw-over machines and so on were quite primitive.
Did you see a lot of changes in anaesthesia for neurosurgery during your career?
Oh yes, quite a lot, because I was trained up as a registrar to do the neurosurgery with Murray Faulkner, who was a leading neurosurgeon. And we didn't have relaxants, so you had to intubate with a huge dose of thiopentone. And when I came to the Melbourne, we did lots of aneurysms and things, but certainly not in New Zealand, or it wasn't being done at that stage. Yes, the surgery's now completely different, and of course the monitoring has made an enormous difference, and the drugs.
And what made you move to Australia?
Well, there was no postgraduate examination in New Zealand, so I came here to do the DA. I was a clinical assistant at both the Alfred and the Royal Melbourne Hospital.
And you eventually became the director at the Royal Melbourne?
Yes.
What were the main challenges that you faced as director at the Royal Melbourne?
The main challenges were the need to improve the status of anaesthesia in the hospital community. The other issue for me was my belief that anaesthetists had to move out of the operating suite and take part in the whole hospital activities, and so I endeavoured to do that.
And you did some things with the registrars too to improve their training and their discussions about their work?
Oh yes, I think there was a big improvement there. We introduced quality assurance meetings.
And how did this lead then to what became the Victorian Consultative Council?
Well, you see, I was very motivated earlier than that, first by Jeff Cooper and Bill Runciman, and the meetings we had in Sydney setting up that APSF, and I was involved in all that, but I'd never been on the Consultative Council. And then suddenly I got a phone call to say that they wanted me to chair it.
And do you think that followed on as a result of Ross's work with the society in New South Wales that had started?
Oh yes, I think so. There was no doubt at that stage that it was terribly important to report mortality, and I agree that it was essential that that's done first. But we've gradually, over the years, recent years, decided that really morbidity today is more important than mortality because of the changes in practice.
So morbidity was always part of the Victorian Consultative Council's brief?
Right from the very beginning, and I've often wondered why. And I think I realised that Geoffrey Kay was the person that motivated it, almost certainly. You see, even today you have to realise that mortality is pretty public anyway because it goes through the coronial system. Morbidity is something that worries people about disclosure. And so it was very slow to build up the confidence of the anaesthetists.
And do you think it's brought about, over these generations, do you think it's brought about any change of practice?
Things like the dangers of Hemixel causing anaphylaxis, and we managed to persuade the drug company to change their ways. That was a bit unpleasant, I might say. There've been, I think, the appreciation of the dangers of hypotension during anaesthesia, and nowadays when we get reports, usually the reporter who said the patient wasn't hypotensive at any stage. So we know that we've got the message across.
Yes. Now, just to go back a bit, you were talking about the Australian Patient Safety Foundation that you were involved with from the start.
It all started, I think, as a result of the American Society putting out some monitoring standards. That was how it sort of started to be discussed. I think you acted more as a detective agency, you might see, just to try and find out why things went wrong. And in my medico-legal work, you had to go over everything in fine print and usually in terrible writing.
Yeah. So what sort of, tell us about your medico-legal work.
So I did go to New Zealand on several occasions because New Zealanders wouldn't give evidence at cases over there for fear of manslaughter and so on.
Now that was a very nasty law that they had in New Zealand for a while about the medical manslaughter.
Yes, that's right. And of course it was very stressful to give evidence in those situations, knowing that if it's adverse for the person concerned, that they could be up for manslaughter.
But it's changed now, hasn't it?
Oh, it's changed now, yes.
Law?
Yes.
It seems to me we have a lot of very significant committees and people like Alan Merry and Bill Runciman and people like yourself have led these committees. Is that something that's happening all around the world?
I think it is happening all around the world, and it must be. I'm sure it's happening more in the USA than, there's an enormous amount of resources go into it. Of course, it's not happening so much in the third world countries, unfortunately, but they've got to get the fundamentals right before they can do all these extra things.
Well, Pat, thank you very much for coming here today. It's been a real pleasure to talk to you and hear about all your experiences. I hope you've enjoyed yourself as well this afternoon.
Oh, thank you very much. I'm very happy to be here in the college where I've been associated for so long.
Good. Thank you.